So thrombocytopenia. So we had too much coagulation, all right, risk factors of coagulation with our Virchow's triad and too much activation of the coag cascade. And if you activate the coag cascade too much, you're going to be utilizing or consuming all of the platelets, right? We activated platelets with the coag cascade. They went from normal to activated, and that's going to cause our coag cascade to also get activated, to also activate our platelets, and that's going to consume platelets over time as these platelets get trapped in a fibrin mesh, right? The fibrin mesh came from where? Came from the coag cascade, right? So the coag cascade is going to activate fibrinogen and turn into fibrin, and that's going to then cause that, like that chicken wire for our platelets to stick into, right? And also thrombin was what made fibrinogen turn to fibrin. So that's going to, that thrombin, ironically, also is one of our activating factors for our platelets, right? So we have all kinds of platelet activation also occurs for the coag cascade. So it's all interrelated. So we got to stop this clot process from happening, because if we keep doing it and keep doing it and keep doing it, we're going to break it down eventually. Especially in sepsis, we make clots, we consume clots, we make clots, and we consume clots, and that can lead to thrombocytopenia, or a low thrombocyte count, a low platelet count. And in the ICU, we're concerned about HIT, and we're concerned about DIC as the reasons for thrombocytopenia.
Knock, knock. Hi, I'm the new med student. Hey, which of these do you like the best? Fibrinopoietin, thromboxylate synthase, or protein Q? What? I don't understand. Oh, it's my turn to make up a new step in the coagulation cascade. I kind of like protein Q. It kind of sounds mysterious, you know? Wait, the coagulation cascade is made up? Oh, yeah, there's only one step, clot or no clot, but we had to make a specialty out of it, so we kept adding things. I've spent hours studying that. Yeah, we kind of got carried away, sorry. There are so many steps. Well, anyway, welcome to hematology. What's your favorite blood cell? Macrophage?
Whoa, nobody messed with this guy.
Okay. My favorite is eosinophil for obvious reasons. Bill, what is your favorite? Red blood cell.
Why?
Well, it's empty inside, and it does the same job every day until it's no longer useful to anybody. And I would describe my body type as a biconcave disc.
So thrombocytopenia. So we have a low platelet count for many, many reasons. If we can't figure it out, guess what? We call it or idiopathic, is a fancy way to say All right, so you got thrombocytopenia, don't know what it is, right? We're gonna do all the tests to figure out what it could be, right? It could be a lack of production. We're not producing platelets. It could be too much platelet destruction. We're destroying platelets. Or our nasty spleen is sequestering them. It's taking them aside, like in liver failure, for instance. Or we have increased platelet usage, like I've been talking about, right? So DIC or HIT could be a reason for a consumptive coagulopathy, where we're consuming all these platelets and we have no more left to play around to go ahead and cause a clot, right? As you mentioned, megakaryocytes were what were shaved off. Where you shave a little piece of megakaryocyte, you get a platelet, right? So where did that come from? That came all the way from the top, from the stem cells in the bone marrow, right? And those can divide into RBCs, they can divide into WBCs, and they can divide into megakaryocytes, which will then pop out some platelets. So bone marrow suppression is a reason for thrombocytopenia, okay? So we have bone marrow suppression because of alcohol, chemo, radiation, cancers. Those can reduce the amount of platelet production, right? That's typically called myelodysplasia or aplastic anemia. They have all these reasons why our bone marrow is not working, okay? It's not producing platelets for some reason. And for this process to occur as well, to go from point A to point B, we need to have nutrients as well, where there's B12 is involved, folate is involved, right? What were those involved for again? Those were for the nucleus to divide, right? So there's like 24 steps to make a DNA, and those steps require folate and they require B12, right? So if B12 or folate deficiency, you're not getting RBCs, which divide extremely rapidly, right? 2 million every second. And you have white blood cells are going to be low, and also you're going to have platelets that are going to be low as well. So B12 folate deficiency causes all cell lines to get get depressed or decrease. All right, so decreased function as well. Vitamin B12, folate was mentioned. Sorry, as far as disrupting, you have plenty of folate and plenty of B12. Well, you might have some folate antagonists or B12 antagonists. So folate, bacterium and methotrexate are known to disrupt the actual function of folate. You have plenty of folate, but you can't use it because you're on these medications. So again, talking to pharmacies, is there anything that's going to cause thrombocytopenia directly, right? That's kind of interrupting the function of my platelets, interrupting the production line, at least, of my platelets. And then we have destruction or sequestration of our platelets, right? So we have antibodies against the are attacking the megakaryocyte itself. We have infections that are causing bone marrow suppression or bone marrow infection, worst case scenario, like osteomyelitis or such. We have severe sepsis that is causing platelet destruction in the bone marrow. We have liver disease that's not making TPO, right, which is what stimulates the production of platelets, and then platelets are low, and then the spleen starts sequestering them. It starts, holding on to them for a rainy day, and that in of itself causes a low platelets as well. Right? Different viruses, different infections can damage the bone marrow and infiltrate the bone marrow and cause a suppression overall. Okay, and again, talk to your pharmacist about different meds that might disrupt platelet function. Okay, and then we have platelet usage, which we'll talk about in a little more detail. We have DIC and HIT. These guys are going to cause a consumptive coagulopathy. You're forming clots like a pro, like a boss. You're forming clots left and right, left and right, left and right, and they can actually block flow of extremities and digits and cause strokes and cause heart attacks and such. But you are ultimately consuming all your platelets, and therefore you have no more platelets to provide your system, and therefore your system just bleeds out, right? So DIC and HIT are one of the more severe consequences of ICU. Okay, hemophilia, that's more of an outpatient thing. That's where you have a genetic reason for not making a clotting factor, and therefore you're always clotting because you're not making clotting factors. So you're using all your platelets up. So labs we kind of touched on already for coagulopathies. But for those other three reasons why we are having a low platelet count, if we're less than 150K, that's why we're here, right? We have thrombocytopenia. FDP and D-dimer we touched on over in PEs and VTEs and such. As you start breaking down clots, you're going to get fibrin degradation products or D-dimers, right? So this whole clotting cascade is eventually going to cause a clot to occur with platelets, right? So platelets are also going to be part of this party as well. And then we get a degraded clot, right? And that clot is what produces my D-dimer. Okay? So that's a breakdown of clots, right? That tells me I'm forming a whole bunch of clots. Either I have a clot in my body that's being broken down, or I'm forming clots rapidly, and they're being broken down rapidly by my body. Fibrinogen, we need fibrinogen to make fibrin, to make that mesh, right? That's a fibrin mesh or chicken wire that's causing my platelets to bind to. If I don't have fibrinogen, I don't have fibrin to capture the clot, right? So if fibrinogen is less than 200, less than 150, right, that's going to cause a thrombocytopenia. Why is it causing thrombocytopenia? I thought this is the clotting cascade. Well, you're going to be using up a lot of platelets to try to fix chicken wire that's that big. Right, so you're going to use a lot more platelets for this guy over here, right, to clot that little hole versus this guy over there, right? So you can see how you're going to use a lot, you're going to consume a lot more platelets, right? What else? So PTT, APTT, these guys are used to measure, is there a coag problem? Why is it taking so long to get from down this intrinsic pathway? Are they on a heparin, for instance, right? Or are they deficient in some of these clotting factors, like in hemophilia and such? And then PT, or your INR, all right? That is a time it takes to get from all the way up here down to my prothrombin time, okay? So that could be a lack of clotting factors. Who lacks clotting factors are liver patients, right? They aren't making all of these things except for von Willebrand's. Where's von Willebrand's at? So that guy's but everything else is low. So therefore, they could have elevated INR because of a coagulopathy of some sort. Liver failure that's causing coagulopathy. So in DIC, everything's elevated. So the INR is elevated, the D-dimer is elevated. The only thing that's not elevated is your fibrinogen and platelets. Those things are low because I've consumed all the platelets, that makes sense, and I've consumed all the fibrinogen, because the fibrinogen is what makes that mesh, right? I'm making clots and breaking down clots. I'm making clots and breaking down clots. So D-dimer is elevated because I'm breaking down clots, right? And my coag cascade is consuming all the coag factors, but also consuming all the platelets. All right, so since I'm consuming all the coag factors, my INR is going to be elevated because I've consumed it all, right? And then HIT. So we'll talk about HIT in a little more detail, but HIT is where you have an antibody against platelet factor 4 that activates the coag cascade, or activates the clots to form. And then sequestration we talked about. We got a spleen that gets splenomegaly, or splenomegaly, it gets big, it gets mega-sized, and that can happen in sickle cell disease, liver disease we talked about, and that can then sequester platelets. So we got to assess, is it your spleen that's causing the problem? Okay, if it is causing the problem, we might have to yoink it out. And if you do take it out, the spleen is very important. It's your biggest lymph node, right? It actually gets rid of bacteria that form a little protective coat around themselves, right? They form a little coat around themselves, right? They have a, what do they call it? They call it, it's a better word than coat, right? It's asking a hematologist. But it has a, this binding, it's not really biofilm, it's like a spore almost, right? But our spleen is able to crack through that deal, right? So who forms that? Pneumococci, meningococci, Haemophilus. They have this outer layer that is only broken down by the spleen. So if someone has a splenectomy, you have to give them vaccines so they don't get these bacteria, right? Don't get they don't develop these pathogens, right? Because these pathogens are easy to cause infection in someone who has no spleen, right? If they don't have the vaccination, and it's a triple vax, is always what you're asking. Hey, can we give triple vax? And you expect to get 3 vaccinations. Sometimes they're like 2 in 1. So HIT. So we have this platelet factor 4 that's being activating, and it's activating the coag cascade, because when platelets get activated, it activates the coag cascade, but also it's activating platelets, and it's consuming all these platelets, right? Because you make these platelets get activated, and then you break it down. The body's like, what the heck? Why'd you make a clot? I don't see any collagen. I don't see any inflammation. What is going on? So you're going to have this activation of platelets, and you're going to consume them all, and therefore it's going to cause a rapid reduction in my platelets. How do you know someone has a HIT? Well, you could look for the antibodies, but that's not the test we usually do. We usually do a test to figure out, is there it's called a mixing test, where you mix 2 syringes of the patient's serum and someone that doesn't have that platelet factor, this little antibody. And if it clots, that means that their serum has that antibody in it, right? So how do you know someone has HIT? It's a 50% drop in their platelets. So it could be 1 month ago, it could be 1 day ago. If they have a 50% drop in platelets and they got heparin at some point, that's causing this activation of the formation of that antibody and the attack of the platelets you could think of, then that's going to be a risk factor for HIT. How you know someone has HIT? We do what's called a 4T score, which I think I'll talk about coming up. But as we know, we're at risk for clots to form. We're activating the clots, and we can have VTE, we can have MI, stroke, right? We could have all kinds of problems, and we're consuming all the platelets, and therefore we get a consumptive coagulopathy or consumptive thrombocytopenia, where we're using up everything, and they're a high risk for bleeding afterwards. So they clot and bleed. So it's like, no, they're risk for clotting, because look at their fingers are falling off, because they're all clotted off. But you look at their labs, and everything is low. Fibrinogen is low, the D-dimer is high, the platelets are low. These are all we're consuming everything. So symptoms. So again, we have all this clotting that's happening, right? And we do what's called a 4T score that gives you points that tells you that you have a patient that has HIT, right? It's a validated score that, if no one believes you, like, let's look this up and say, look, I got clots, I got digits that are falling off, and I have a coag cascade that is being consumed, right? My INR is high, my platelets are, my D dimer is high, my platelets are low, fibrinogen is low, and I have all these clots happening, and I got a 50% drop, and they got exposed to heparin. Well, shoot, that's really kind of sealing the deal for someone that has a heparin-induced thrombocytopenia. Okay, so this platelet factor 4 is binding, is activating, yes, the coag cascade, but it's also activating so many platelets that it's causing consumption of everything, right? So how do we fix this? Well, the treatment is to stop giving heparin, right? That's one of the first steps, stop heparin. Don't give warfarin, because warfarin is going to cause gangrene. So that's another good reason not to give warfarin, if that's going to cause a worsening coagulopathy and a worsening gangrenous skin manifestations. Right, so what else? Give platelets? Well, shoot, their serum is what's causing the problem. So their serum has this antibody in it, right? It has this antibody inside of it, and that serum, if you give them platelets, is just going to bind those platelets and activate them. So that's actually one of the tests we do. We do this mixing test that's going to, we're going to assess, hey, is their serum causing the problem, or is the platelets causing the problem? Is there something else going on, right? So they do what's called a mixing test, and they see, is there a consumption of the platelets or not, right? And that's how they confirm if someone has hit. You may hear of a serotonin assay, right? When a platelet gets activated, such as by the serum of the person that has hit, that platelet releases, all kinds of factors. It releases ADP, releases thromboxane A2, releases all these fun stuff. But one of the things it releases also is serotonin. So we can identify if there's serotonin being released or not. Is it accurate? Not so much. But what is accurate is this mixing test. That's one of the go-to tests to figure out if someone has hit, if they have that 50% drop in platelets, and they have a lot of scorage on the 4T score, right? They got this dropping, they got thrombosis happening, they got thrombocytopenia happening. That's going to lead to someone that is a high risk for hit. All right, and then DIC. So DIC stands for Disseminated Intravascular Coagulopathy, but also has extremely high mortality, so it's also known as death is coming. It is a extremely consumptive coagulopathy, more than hit. So you're consuming all of these platelets and all of these coag factors, right? So we have some kind of trigger. Most commonly, it is sepsis. That's the most common trigger for this consumption of all of these tissue factors and coag release and platelet utilization, and we are going to have a yes, clots being formed, and you're going to have a digital necrosis and toe necrosis and lack of flow to the extremities, but also you're going to consume everything, right? So we have a lot of clots being formed, therefore D dimer is elevated. We got fibrinogen and platelets being utilized, and the coags are all up because we have the time it takes to clot is extremely long. So we're going to have a lot of delay in our coag times. So our INR is high, our APTT is high. That's a sign of D dimer, right? So it's an imbalance between clot formation, which sepsis, inflammation causes, and then our body says, wait, why are you making so many clots? Let's give some anti-inflammation, right? So you then cause a breakdown of those clots, and then you make more clots because of inflammation, sepsis, and you break it down. You make some more, you break it down, and in the end, you've consumed everything. You've consumed all the platelets, you've consumed all the coag factors, and you have this excessive bleeding that will occur, okay? So usually what we're doing is treating the underlying cause with sepsis. If it's cancer, that puts a high risk of triggering DIC. Trauma is another high risk factor for causing body-wide inflammation, a surge response that's out of control. And ironically, these patients get heparin, right? As long as their coags are not too bad, the platelet's not too bad, you give heparin to stop the excessive clot formation. So there's a point where it's too late and we really can't do anything, but heparin can be given to stop the consumption of platelets. Okay, when they're bleeding, we give FFP. If the platelet count drops below 50K, we'll give platelets. If fibrinogen is low, we'll give fibrinogen. So those three things are what we are doing to try to mitigate the DIC, and hopefully we can fix the underlying trigger, fix the sepsis, cancer is not going to get fixed immediately in the ICU, but trauma, we can try to avoid the continued surge response from the trauma by repairing whatever might be going on, or stopping the bleed. That's because bleeding and bleeding and bleeding is also consuming and consuming and consuming platelets and coag factors.